Welcome, and thanks everyone for joining us today. My name is Darren Sommer. I'm the Chief Operating Officer at Genpact, and today I'm delighted to have two guests with me. First, Dr. Michael Meena, ophthalmologist and assistant professor at Harvard, as well as Professor A.G. Agarwal, the founder of the Creative Destruction Lab and professor of Rotman School of Business at University of Toronto. So we're really excited to talk to you about a bunch of topics, two really important ones. First off is, how do you reopen the business? How do you reopen business, return people back in a safe way, leveraging rapid antigen testing? And the second thing is talk to you a little bit about something called the Rapid Action Consortium that's involved in trying to get businesses back to work in the United States. So today, if you have questions, please feel free to put them in the chats and to get through those questions. So let me jump right into it. So Dr. Meena, I wanted to start with you with a couple of questions. One is, why is rapid antigen testing important today?
Yeah, well, the goal is really rapid testing is still crucial because testing is our eyes. It's how we know if the virus is around us. In the context of vaccines, a lot of people are now asking, do we even need to test? Do we need to know? The short answer is yes, but especially in the context of rapid testing, we can have programs that can be dynamic. If cases start to increase or decrease in certain areas, you can increase the amount of testing or decrease the amount of testing and throttle it in a way that is commensurate with what the pathogen is doing. As we move from now into the summer, we're likely going to see reduced cases. That's going to be a massively needed reprieve. But my concern very much is that as we move into the fall and winter, we're not going to get rid of this virus. It's going to continue spreading, and it will probably hit seasonal peaks again. Not as big as last year, but we will likely see cases emerge again. There will be outbreaks, usually probably localized outbreaks. But we'll need to deal with those as they come around. We'll need to know that they're happening and be able to limit spread. Rapid testing is one of the most crucial ways that we can limit spread. And it's not just the test, it's what the test means. The test empowers people to know that they're infectious and be able to stay at home, for example, and not go to work. And so if we start to see new cases emerge, especially as we move into the fall and winter, when in particular the vulnerable and elderly may be starting to lose some of their immunity, virus variants that are slightly better at evading some of our immunity will just grow in prevalence. When those things happen and we start to see new surges or resurgence of cases, we'll want to be able to know where those virus particles are, who's infectious, and be able to limit spread before it gets out of control so that we don't have to close things down. This is all preventative so that even in the midst of outbreaks, we can keep things open, keep schools and businesses working appropriately, even in the midst of new.
Well, that's great. And a question that I know a lot of people have asked me personally, Dr. Meena, is, are vaccines really the holy grail? I mean, are you truly immune with vaccines, or is testing still going to be relevant in light of vaccines?
Yeah, well, I wouldn't use the term holy grail, but vaccines are absolutely essential. I mean, that they are our exit plan, at least in high-income countries right now. Do they mean that you can't transmit? I'm not going to jump on that bandwagon yet fully. I think we've already seen that, in fact, that vaccinated people can actually have fairly high viral loads. Whether a vaccinated individual is likely to transmit and cause disease in another vaccinated individual is very unlikely. You know, that's not, at least right now. But can a vaccinated person still carry the virus and transmit, especially once we get, say, 6 or 8 or 10 months out from that vaccine? It's very likely that many people will, in fact, be able to carry the virus, might still be able to transmit. And in particular, you know, ideally enough people will be vaccinated so that it loses its importance, that even if you transmit to somebody who's been vaccinated, that it's not going to harm them. But if we're not careful, we could find ourselves in a position where we do have the vulnerable class, which happened to be the elderly class in this pandemic, Elderly people don't hold on to their immunological memory as well as younger individuals. And so we might end up seeing that a vaccinated individual could get exposed potentially from a younger person, for example, or just a younger person might get in close contact with an elderly who's been vaccinated, but say a year earlier. It is, I think, what we should plan on seeing, hope that it doesn't happen, but plan for it, is that outbreaks and new cases will be seen amongst particularly the elderly who have been vaccinated. And we will probably see cases that lead to hospitalizations and deaths, ideally in much, much lower numbers. But it's something that we need to be aware of and ensure that we're able to mitigate if we start to see it.
Got it. Professor Agarwal, I had a question for you. What is this Rapid Action Consortium? How does it work? Why would someone join something like this?
The Rapid Action Consortium is a group of companies that are working together to deploy rapid antigen testing for workplaces in the United States. And so I think there's three important things to know about this. First of all, the systems can be quite workplace friendly. In other words, the idea here is that they are reasonably easy to administer. They are reasonably low cost, and they are reasonably have limited disruption. So in terms of easy to administer, when we first started doing rapid antigen testing, we were under the false belief that this was just a no-brainer. You order some rapid antigen tests, they arrive in a FedEx truck, and then you're done. How hard can it be? You're just putting a swab in your nose. It turns out that it is not trivial. There is some work to do. There is a number of steps to be compliant with public health, and then there's all the, how do you inform your employees? If you're unionized, how do you inform your unions, your management? How do you register people? Once you're administering these tests, how do you dispose of used tests? How do you handle infected people? So there's a whole bunch of steps. But we've now, the Rapid Action Consortium has streamlined this so that companies that want to put these together can join the consortium. And it's really a sharing group that just creates an easy and fast on-ramp. Also gives companies some confidence when they see their peers doing it. Then it also just reduces the uncertainty and the risk to deploy one themselves. And so they're able to do that. They've figured out all kinds of clever tricks for bringing the cost down. And keeping the lines short so that people can enter a building and go through that quickly. And it's not disruptive. In other words, they can be tested and get the results in about 15 minutes. And because they're, which we define as twice a week, that they often don't even have to do it at the front door. They can go in and begin their day and just at some point it's convenient to them, be tested. So the whole thing has been quite streamlined and makes it easy rather than daunting for companies to get started.
Got it. And Professor Agarwal, I know the Rapid Action Consortium in the U.S. emanated first from something you launched in Canada with the Creative Destruction Lab. Do you just want to talk a little bit about the Canadian experience and how it evolved and what impact it's had?
Sure. So in Canada, this was launched the first rapid screen. We call them screens in Canada, not tests. Just to sort of remind everybody, it's not a medical diagnostic test; it's a screen. And so we did our first rapid screen at a pilot site on January 11th in downtown. Now those screens are being operated at about 70 sites across the country from coast to coast. And they are being deployed in retail settings, in manufacturing settings, in office towers, in large like sporting events, like a sporting arena where the former NBA champions, the Raptors play. They are being deployed in industrial settings, so big oil and gas facilities. So these pilot sites now have been demonstrated to work at a variety of different types of workplaces, and everyone required a little bit of tweaking here and there in order to get them going. Also, in Canada, the different provinces have different health guidelines, and so it requires some adaptation. Even the same company that's deploying a rapid screening at multiple sites across the country sometimes has to have slightly different procedures to comply with the public health in each province. Different states having some different regulations. So anyhow, it started off with 12 companies. Now there's roughly 35 or so that have pilots deployed, and a whole bunch more. The plan is to take another 300 companies through the program over the next 3 months. So that's the idea of how it's working in Canada. So far, so good.
That's amazing progress. And Dr. Min, I guess, the United States obviously is different than Canada. Are there U.S. regulatory barriers that we should think about when we're launching rapid antigen testing?
Yeah, absolutely. There have been significant barriers that have essentially limited the access to rapid antigen tests for most Americans up until very recently. The FDA has sort of struggled to get over-the-counter testing authorized, but until very recently, and now we do have actually 2 tests that are these simple, accessible paper strip type of rapid antigen tests that are now authorized. But CLIA waivers, especially for businesses, if you're not doing the test at home, then you start to get into issues of CLIA and what you actually need to account for when you're going to start a testing program up at a work or business. That needs to be taken into account as one of the barriers that's going to have to be gotten over. Each state deals with CLIA and CLIA waivers slightly differently. Ideally, we would have these tests all be not requiring any CLIA waivers, and if a company wants to offer the test, great, but that's not how things are going right now. It's still a state-by-state decision how to deal with it, how easy a company or a school or business has to get a CLIA waiver is it's not standardized. And so that is something that really does have to be taken into account. And it turns out that those little things that aren't really thought of beforehand end up being the barriers. Companies across the country have tried to set up testing programs, and then when they get into it, they realize, oh, there's this checklist of things that we need to do, and we really don't have the expertise to do it. And so they abort. And that's generally how things have happened throughout the pandemic here in the US. And it's been largely red tape, unfortunately, which has limited our ability to have eyes on this virus and our ability to actually use these crucial tools to limit spread.
Got it. But I do think these 2 new over-the-counter solutions have been approved will be a game changer, and hopefully we'll see more of them in the United States. Professor Agarwal, you've often referred to COVID as not just a health problem, but an information problem. Can you just explain what you mean by that?
Yeah, sure. The way you can think about this is most people have been thinking about COVID-19 as a health problem because when you get sick, you go to the hospital and it feels very much like this thing is a health problem. But in terms of the macro impacts of it, and remember, we're focused on asymptomatic people. So everything we're talking about here today is asymptomatic people. That means a person's feeling fine, they look good, they feel good, they have no symptoms, they show up to work, and they don't realize it and they accidentally, infect somebody at work. That person then goes home. They infect people on the way home, in the subway, at the bank, and of course their family members. And that's how this thing spreads. So the key point is, depending on where you are, the infection rate, let's say for asymptomatics, is something like 1 in 1,000. So that means for one person out of every 1,000, COVID-19 is a serious health problem. For the other 999, COVID-19 is not a health problem. They're not sick. They're not infectious. They're fine. But in the absence of knowing who the one person is that's infected, we end up treating all 1,000 like they could be infectious. That's why it's an information problem, because in the absence of the information of who the one person is, we're treating everyone like they could be infectious, and that is shutting down big parts of the economy. And so, I should point out that this is, feels like an everyday panel. You got a couple of people on here talking about it. But one of your guests, Dr. Minna, is, he is really the world expert in like the studies of the efficacy of rapid antigen testing. And in Canada, we built a lot of our plan based on his research. So the idea was we said, okay, this is an information problem. How do we solve the information problem? And we looked at the various solutions and just started downloading a lot of his research papers. And the punch, like, he made it very clear. There's a handful of people in this domain. He was, I think, the most, from at least from our vantage point, the most clear and unequivocal in terms of the role this could play in solving information problem. And so now, Darren, we have it's set up this information solution, which is rapid testing. For example, 2 weeks ago, one of the companies in our consortium has a critical warehouse. They were not running a screening program at this warehouse. They were running it at other parts of their business. And they have 3 shifts. And the first shift, a bunch of people got infected. Second shift, a bunch of people got infected before they knew it. In other words, the infection happened before they knew what was going on. And then in the third shift, by the time they got the shift done, they realized something was going on. So they shut it down, cleaned the place, and then they set up a screening system at that warehouse before the third shift came on. And they were able to, they were screened out a few infected people from the third shift, and then they were able to keep operating. If they hadn't done that, they would have had to shut down the facility for 2 weeks while everybody, quarantined. So it kept that screening system, enabled them to keep the warehouse open rather than shutting down for 2 weeks. They shut it down for 24 hours. And we are getting now similar stories in other settings in across the country. And so here's the thing that I find just stunning. Like you just heard Dr. Minna explaining that there's some regulatory issues here and there. It's just inconceivable to me that every company is not doing this in the following sense. There are children in Europe who are putting swabs in their nose. All this is putting a swab in your nose. It's not one of those very deep, brain ticklers. This is just a shallow swab. You do a shallow swab, and then 15 minutes later, you got a result. And so it could not be easier, and it just solves the information problem in a very efficient way. So the fact that we have, I won't comment on the US, but in Canada, we still have parts of the country where it's highly regulated of an adult basically, putting a thing in their nose, is at some point we're going to look back on this and look at all like in Canada, in my province, Ontario, we have tents set up in the parking lots of hospitals because the hospitals are overflowing with cases right now. And we're going to say, I can't believe that we regulated adults putting a swab in their nose. It just will feel like, hard to imagine.
Yeah, it really is. And I would say we're feeling that right now. We have a big operation in India, and we're still not allowed to use those kinds of tests in India either. So we're pushing hard to see if we can make that happen. A couple of questions came in, and tying back to a couple of things you talked about, Dr. Minna, that are kind of interesting. So one is, you hit on 2 things. You talked about the duration of which the vaccines are going to be effective for people. And you kind of hinted at that, or it sounded like people who are older, that this vaccine may not last as long, whether it's 9 months, 6 months, who knows. But can you just shed a little light on what is at least right now, what's the expectation for how long will we have protection from the vaccines?
Yeah, well, the first thing is biology is on a massive continuum. So some people will likely retain immunity very well for a long time. And then on the other end of the distribution, there's going to be some people who don't even take to the vaccine the first time they use it. And there will be immediate breakthrough cases. And then there's going to be this whole big distribution of people in the middle where we'll see some people start to wane with their immunity earlier than others. So there's not going to be an answer is an important piece of this. The same way that Immunity is on a continuum. The duration of immunity is on a continuum. But what we do know is, in particular, the elderly, once you really hit 65 or so, your immune system just starts to break down on average. Some people, again, will do just fine until they're 105. But other people will really start to have, their immune system will start to really reduce in its ability to retain immunological memory very quickly. And this is why, for example, older individuals start to get things like shingles again. And other infectious diseases end up becoming more and more detrimental. Things that when they were 40 wouldn't have been a problem start to kill people when they're 75 in the absence of antibiotics, for example. So we just have to be very cognizant that that we don't have the data yet. But what we can say is we can look at all of this data that we've accrued over many decades of understanding viruses and immunity in general in the elderly, and recognize that elderly are rare that we give somebody a first vaccine to a pathogen they've never seen once they're already over the age of 65. And unfortunately, it's just a fact that at those age categories, the retention, the actual cellular machinery isn't there in the same way that a younger person has it to actually retain that immune protection. And so we have to wait and see. So I unfortunately don't have a clean answer to give in terms of how long we should expect it to last. But I think there is one thing we should expect, which is that particularly in the vulnerable elderly people in our communities, we should not expect to see this incredible 94% level of protection persist for a long period of time in many of the older generations.
Yeah, and that kind of links to another question that just came in as well, where people are saying, well, is this a situation where you either get vaccinated or you get tested, or is it a situation where even if you're vaccinated, it's better to get tested as well? What are your thoughts? Especially as you hinted that in the fall, we should start to see this thing pick up again. So is it vaccination and testing, or is it vaccination or testing? Thoughts?
No, this is an and. These two are very different. And so this really gets back to Dr. Agrawal's comment, which is this is a public health. This is an information problem. It's a public health problem. And this is where things, especially when it comes to testing, have been so confused by physicians and scientists the world around. In this pandemic is not about our own health. It's about ensuring the health of our neighbors and limiting spread and keeping the economy running, for example, and limiting hospitalizations, of course. Getting a vaccine is about that, but vaccinating yourself is also going to give you protection at the medical level, at the clinical level. It's going to protect you from disease. It will ideally also help protect you from spreading. But getting a test is really a public health good. It's why individuals probably shouldn't be asked to pay for their own tests and never should have in this pandemic. It's not a medical tool. This is a public health tool. And so these are very different things. And we don't want vaccines to be the only tool we have at our disposal. That's probably a mistake in a pandemic like this. And it has been up until today, or really up until the last couple of months. We have just had a laser focus on the development of vaccines. And at least in the United States, a result of that laser focus was 500,000 dead, who probably a large fraction of them, if not over half, probably didn't need to die if we had paid more attention to other mitigating strategies like tests. In the future, I think this is an and thing. We need both. That's just, they have different places in a pandemic like this.
Yeah, and one really interesting statistic for us, so we've been testing in our facilities for quite a while. We made it optional originally to say, well, optional that people would come back to the office. It wasn't mandatory. But once they came back, we also made it optional if you would want to take a test. And I thought this was really interesting. Prior to this week, it was optional. And we had roughly 60% of our people that we expected to show up to the office never showed up. This week, we changed gears and we said, we're going to make this test mandatory. If you're in the office, you don't have to be in the office, but if you're coming to the office, test. The interesting thing that we saw is we went from 60% shrinkage to 4%. So 96% of the people actually showed up to the office who were thought. And when we actually asked the employees, they said, I feel so much safer knowing that everyone's getting tested now versus just some people getting tested, because I don't know who's as Dr. Agarwal said, I don't know who's positive and who's not positive and not showing symptoms. So listen, this Rapid Action Consortium, I think, is a super important tool in the United States. I believe there's power in numbers. I believe the more companies that become part of this thing, we're just better as a group. Hopefully, we'll push through some of these regulatory barriers. All the companies I speak to all have the same questions about vaccines and can I have people vaccinated and not vaccinated together? And if I do I make the non-vaccinated people wear masks? How do I get these testing working in the home? So there's so many questions that we all have. So I believe it's crucial to join this. But maybe Professor Agarwal, you can talk about how do you join the Rapid Action Consortium? Is there a cost to join this? And what expectation should those companies, like what do those companies need to do to become part of this? What kind of investments do they need to make?
Sure. So first of all, the sign-up cost is zero. And so it is free to join the consortium. Nobody here is trying to make a profit from this. The idea is to try and reopen the economy. And so to give you a sense here, they join the consortium, and then the companies attend these. Attend these weekly operations meetings, and so they're basically playbook. The playbook has all the details, right from how do you sign up your employees, how do you message, how do you do the messaging, how do you communicate with your unions, how do you train your managers, what's the layout on the floor, depending on if you're an office tower or if you're a retail outlet or if you're manufacturing, and how do you manage the data? In other words, as people are getting tested, you have a system for recording the data so that the HR manager can keep track. Okay, everyone's that's in the building is being tested. Count of how many positives, if there are. Like I said, right now our numbers are roughly 1 in 1,000 people are infected. So there's a playbook for doing all that, and then in these weekly meetings, there's effectively a process for reporting and innovations. So, for example, the first company that went from, in the beginning, all the companies hired healthcare professionals to administer the swabbing. Then the first company said, we can really reduce the cost if we have a non-medical professional, and some of the provinces allowed that. So then they tried it, and as soon as they tried it, they explained how much it worked, how much effort did it take to train a non-healthcare professional to do it. Then a bunch more started doing it. Then another one said, well, rather than having a non-healthcare professional swab, why don't we let people swab themselves, and we have a non-healthcare professional just observing them swab to make sure they're doing it properly. And then another company said, okay, rather than doing that, what if we just have an iPad sitting there with a person that's observing via an iPad remotely? Then we had companies saying, hey, why do we need to set up a station? A lot of our workers are remote. Can we make a mobile testing unit? Then we had companies that said, just like you just said, Darren, rather than making it voluntary, what if we make it mandatory? Everybody likes watching somebody go first. They try it. They say, okay, here's what's working. Here's what's not working. We're surveying our employees. We're talking to our unions. And then they come back and they share. And so not a single company that's in the consortium is in the business of rapid testing. So in other words, they're all doing other stuff. Their business is other stuff. They just want to get this system in and as efficient as possible. So they're very happy to share with each other. So they all kind of race up the learning curve. So it's free to get in. There's a website you can sign up. I assume you'll just post it. And they sign up, and then they go through a little bit of an onboarding, and then they attend these weekly operations meetings, and they get a lot of hand-holding to help them get started.
That's great. Well, listen, I would just one last thing I just want to say on testing. We have a large operation in India. We have roughly 65,000 employees in India. So we've been doing this since November, and I would say, thank God we have the facilities in India that we have, because right now, if you're following the news, India's been devastated with COVID, and all of the government funded as well as the healthcare provided testing facilities have essentially collapsed, where to get a test, it takes days, if not weeks. So we've converted our testing facilities that we typically use for employees in the office, we've created a drive-through for our employees and their families to drive in and get a test. And I would say, thankfully, we have those facilities so we can take care of people that otherwise would not get taken care of. So on behalf of GenPact, on behalf of the Rapid Action Consortium, Dr. Minna, thank you, and Professor Agarwal, thank you. I should just mention one last thing. Both Professor Agarwal and Dr. Minna are both members of the Rapid Action Consortium. They're both in the student and give us guidance along the way. So thank you guys very much for your time today. Really appreciate it.
Absolutely.
Thanks very much, Darren.